Pyeloplasty is used for PUJ obstruction. So what that is patients have a renal pelvis, so the kidney drains urine into something called the renal pelvis, and then there's a thin tube called the ureter that takes that down to the bladder. When you have a narrowing at the renal pelvis, that obstructs the kidney, and that's called a PUJ obstruction. Patients usually present with symptoms such as, it's very similar to kidney stones with severe pain. Sometimes it's incidentally found. Traditionally, this has been treated with a big open incision, and it's quite a large incision right along the loin area, and it's a 2 to 3 month recovery, 7 to 10 days in hospital. I have been performing PUJ treatments in a minimally invasive method, so I presented this nationally and internationally. For some patients, we do it endoscopically through the eye of the penis. We go up with a little telescope. We use the holmium laser and incise the obstruction, put a balloon that stretches it up, we put a stent in and leave that in for 6 weeks and then take the stent out. That's called a laser endopylotomy. The risks of that are that you can get bleeding if there's some adjacent vessels there. It's not very good if the blockage is very large, but it's good for patients who have had failed treatment and patients that don't want to have any form of other surgery. The success rates are slightly lower than with surgery, with open surgery, with a success rate of about 75% or so. But I presented this data internationally and we've been very happy with those outcomes. The other way of treating this is either via laparoscopic or robot-assisted method. And I've been very fortunate to have our robot donated to our hospital. I've presented the robotic pyeloplasty data, and really I think it's transformed this condition. Basically, patients just have small incisions made. We have the robotic device that comes in and attaches. I unscrub, I sit in a console, I move my hand controls. As I move my hand controls, the instruments inside the abdomen replicate my hand movements. We have gas pressure in the abdomen, which creates space. We actually have a third arm, a spare arm, that I press a pedal on and it activates to retract the bowel. So the narrow segment gets excised. The robotic arms have more degrees of movement than your wrist, so we can move the instruments around. We cut the narrow segment and then we can stitch it up. So the robot allows 10 times magnification. It's a three-dimensional view. It's like doing the operation with an operating microscope, and we do a very, very accurate joint. So patients are usually out of hospital in about 2 days with this method, but most importantly, it's their recovery. They're back up and about in about a week or so, as opposed to 2 to 3 months. I also do this laparoscopically, but the instruments, when you do it laparoscopically, just open and close. They don't rotate around, and it's much harder to do a very accurate joint. So I believe that really robot-assisted pyeloplasty should be the gold standard in patients with PUJ obstruction, and certainly patients who have PUJ obstruction should at least be informed about this treatment option and consider this option. I think if patients really knew about it, the majority of patients would elect to have this done. So far we've had an excellent success rate with all our patients having complete relief of obstruction, and really the literature shows the success rate is 95% plus. So previously I used to do a lot of endopylotomies rather than the open incision, but now patients tend to go for a robot-assisted pyeloplasty with a higher success rate than the endopylotomy, and they have the advantage of minimally invasive surgery.